Yeah, అదే yeah. అది ఇది ఎలా ఉంచేసి
ఛార్జింగ్ ఉందా దీనికి? ఛార్జింగ్ దీనికి
అనిల్ స్టార్ట్ చేద్దాం. పవన్ విల్ స్టార్ట్. ఇట్స్ 8:10.
Sir. Good evening and I welcome all of you to this third webinar of the month series, third edition. And as you all are aware, today being the World Alzheimer's Day, this topic is being planned and IPSTSB initiative, sir. And introducing today's program, this is the speaker is Dr. K Chandra Sekhar, sir. And chairpersons, today's chairpersons, I invite George Reddy sir to the meeting. Sir, George Reddy sir, welcome sir, President IPS Telangana State Branch. I invite Dr. Minaz Nasirabadi sir, Vice President. I invite Dr. Uma Shankar sir. Thank you sir for coming, for being here with us. Now, today's speakers, today's speaker Dr. K Chandra Sekhar sir, and his chairpersons Dr. Abhi Anand sir and Satish Babu sir. Now, with this, I hand over the proceedings to George Reddy sir. George Reddy sir, please take over, sir.
Yeah. Thank you, Pawan. Respected Dr. Raghuram Reddy sir, Dr. Chandra Sekhar sir, Dr. Anand sir, Dr. Satish Babu sir, and Dr. Uma Shankar sir, and all the office bearers of IPSTSB, and all the members of IPSTSB, good evening. At the outset, first, I think I thank Dr. Chandra Sekhar sir for readily accepting to be the speaker, and for sure we all will agree that there can be no other better speaker than Dr. Chandra Sekhar sir to deal with this topic and relevance for the day, World Alzheimer's Day, and we know how active Dr. Chandra Sekhar sir is in helping in spread about the dementia, and at least over 20 years I'm observing sir doing a lot of activities from his end. I think is definitely a motivation, and definitely it is that sir helps me many times to deal with these patients, and I think closely follow up with Dr. Chandra Sekhar sir has given me a lot of insights to deal with patients with dementia, Alzheimer's. Today's webinar, I thank Pawan also for choosing the chairpersons. Thank you, Pawan. In today's practice, at least every day in our clinical practice, the day doesn't end without seeing a person, an individual suffering from dementia. I think thanks to the awareness, and might be the caregivers are able to bring the patients for help. And definitely our psychiatrists and our psychiatric practice, we are doing much ahead better with the pharmacotherapy. And more important is, I think, as Dr. Chandra Sekhar sir many times tell, caregivers guidance is very important. I think we need to really look at that, because it's ultimately the caregiver. And though we know that the medication part is limited, and though still we know that there's not much progress in dealing with dementia, but particularly diagnosing, and then again the care in our clinical practice, use of pharmacotherapy, subtle doses, which bring a lot of change in these patients, and the quality of life in these patients can be definitely be changed by our psychiatric practice. And we really have to look into the guidelines and help the patient, because elderly dosing is a major task. And I think without taking much time, I will introduce the chairpersons today. Dr. Anand sir needs no introduction. I'm very sorry. Anyway, just to introduce sir, with your permission, sir. Sir did his DPM and then DNB, and sir was the professor at IMH. He retired from IMH, and sir is currently working as a professor of psychiatry at Mallareddy Institute, Hyderabad. And he was a senior resident at Jipmer, Pondicherry. and he did a lot of research work at NIMHANS, particularly in the psychological correlates in recovery of schizophrenia, worked on computerized EEG, worked potentials, so many things and so many awards, but I think Sir has only mentioned one, Dr. S.S. Jairam Award in the South Zone Conference for the year 1999 is areas of interest, data analysis and research in mental health. And sir, you owe us one topic on statistics, sir. You should be our speaker again, once again, sir. Thank you, Anand, sir. Dr. Satish Babu, sir. Again, Satish Babu, sir, needs no introduction. Sir is the a very popular practitioner and a senior practitioner from Khammam, and he's the director for the Krishna Nursing Home, and he did his MBBS from Kakatiya Medical College, and then later did his MD from Manipal, and he's now currently a professor of psychiatry at Mamta Medical College, and he's a past president of our IPS SYL AP branch, and he's a member of IASP from India, and sir is our president for the Telangana Private Psychiatric Hospitals and Nursing Home Association. And one thing interesting I learned from sir is in the recent days, sir did his general practice for about 8 years. Then with great interest, sir has taken MD Psychiatry at Manipal. I think this shows his commitment towards psychiatry. Thank you, sir. Satish Babu, sir. With this introduction, I hand over the mic to our chairpersons, Dr. Anand, sir, and Dr. Satish Babu, sir. Thank you, sir.
Thank you, George. Thank you, the office bearers of IPSTSB and dear members. Today we have a very eminent psychiatrist and speaker, Dr. R. Chandra Sekhar, who has probably done the largest work on dementia, especially in the care, not only in Hyderabad, not only in the two Telugu states, but probably in India. Why I am saying this is, for the last more than 3 decades, he has been consistently working in this field of dementia, especially the care of dementia. He has been an active member of the Alzheimer's related Disease Society of India, ARDSI, Hyderabad division, and also Geriatric, which, as all we know, that most of the dementia cases are in Geriatric. Why I'm saying again, this is because neurologists are very good in diagnosing the cases of dementia, and they are more interested in treating the treatable causes of dementia and interpreting the scans and other investigations. But when it comes to the care, actually, which is more important, what is more important, the psychosocial care is the most important thing in especially the neurodegenerative dementia. I don't find any other person apart from Dr. K Chandra Sekhar, who is now the director of ASHA Hospital. And it is very apt that he is speaking on the most important practical aspects of the early diagnosis and care of dementia. As we know that dementia from the WHO stats that the low middle income group countries, there is a wide gap between the developed countries and where the stats show that it is increasing in the low middle income group. That's because of the lot of disadvantages which people have in these countries. And we also know that there is no particular biomarker. Everything is in investigation, and there is, although a lot of treatments have been tried, especially what is called as the beta amyloid immunotherapy and vaccines and even stem cell, these are all very experimental right now, and the crux of care is especially in the psychosocial care. And this is what is very important, and we have the speaker who is going to speak on these aspects. I request Dr. Satish Babu to kindly formally introduce Dr. Chandra Sekhar. Dr. Satish Babu.
Sir.
Yeah.
Okay, sir. Sir, I think Dr. Chandrasekhar sir, I think he doesn't need any introduction. Am I visible, sir?
You are audible.
Okay. Dr. Chandrasekhar sir is Director and Senior Consultant in Neuropsychiatry, Geriatric Psychiatry at ASHA Hospital, Hyderabad. He has been in clinical practice since last 40 years. I think the areas of interest is neuropsychiatry, geriatric psychiatry, and mental health legislation. He has been guest faculty for various institutions. Today, actually the topic is diagnosis and care in clinical practice. As we know, today is Alzheimer's Day. It is observed every year on 21st September. First, it was observed in 1994 at Edinburgh. Actually, the World Alzheimer's Day it promotes Alzheimer's Association around the world to encourage better policies at regional and institutional levels. The theme, no dementia, no Alzheimer's, KNO. Last year also the same theme was there, but last year it focused on early warning signs and diagnosis of dementia, and also the effect of the COVID-19 pandemic on the dementia community around the world. But this year, the focus will be on post-diagnosis support for dementia. As you know, even now, the awareness is very much needed. The common public thinks that Alzheimer's dementia is it's a routine process of aging. Because of that, the people are getting Alzheimer's dementia. That is a common belief in common public. Around 55 million, that is 5.5 crores of people are suffering from Alzheimer's dementia according to 2020 statistics. So the awareness is very much needed. To create awareness, Alzheimer's Association has given, say that Alzheimer's walk to our rallies to create awareness, and at the same time seminars and webinar is also one of the awareness creating this thing. Thank you very much for giving me this opportunity for this thing. And now I hand over the mic to Dr. Chandrasekhar sir.
Thank you. At the outset, I am very thankful to the Telangana branch of Indian Psychiatric Society for having given me this opportunity to dwell on my favorite topic about the management of dementia. Thank you, Dr. Anand, my esteemed colleague and today's chairperson, for saying few kind words about my interest in dementia. If I look back, the World Alzheimer's Day is being observed by probably the psychiatrists only the last 5 to 6 years, or maybe at the maximum the last 10 years. Before that, it was very difficult to convince my colleagues to talk about Alzheimer's or to talk about dementia in general. Gradually, I think we have realized, or most of us realized, that dementia as a disorder is occurring more commonly in our day-to-day practice. Gone are the days when we used to think that this is a rare disorder, once in a way only I will see. As Dr. George was pointing out, almost every day you may come across a case of dementia. And this has been happening for this observing the World Alzheimer's Day has been happening for the last few years. If I go back down the memory lane, I think Dr. Anand would remember that in about 25 years ago, I was a part of a larger study known as 1066 dementia prevalence study in India. I was one of the participants. And because I didn't know how to go about it, I took Dr. Anand's help in conducting those study along with his postgraduate student, Dr. Ajay, who ultimately had to do an MD thesis. And this we introduced a topic for him and we went through that research process. I think Dr. Anand would recollect those days when we had to do that study. After that, probably my interest further evolved more into the caring of dementia rather than in the research work. Though I participated in few research studies, my main area of interest was in how to improve the care for dementia. Then let me go into my formal lecture with these few comments. Let me share my screen and to share the screen.
Sir, it is being shared, sir. You just have to open your presentation.
Where is the presentation? I'm just looking for it. My desktop. I should see my desktop, no?
Can you minimize this screen, sir? Yeah.
It's visible?
Yes, sir.
It's okay now?
Yes, sir.
Visible and I'm audible?
Yes, sir. Yes, sir.
Okay.
Visible and audible.
Right. Thank you. Today, I would be probably talking more about more practical aspects rather than a lot of academic aspects about Alzheimer's and basically, because that I feel would be more useful for most of the clinicians. If you look at it, there are almost an estimated 10 million new cases of dementia each year worldwide, implying one new case every 3.2 seconds as per the WHO statistics. It is estimated that 5.3 million people above the age of 60 have dementia in India in 2020. It equals to 1 in 27 people above the age of 60 in India as dementia. This is a huge number, and unless almost probably in the next few decades, it is going to reach epidemic proportions. If you look at it, especially in the low and middle income countries, there is going to be a surge of the cases over the next few decades. Already we are somewhere in the 2020, between 2020 and 25. If you look at it, almost in our countries is 38.72 million cases of dementia, which one would come across. And are we really geared or are we really prepared to take care of such a huge patient load? If you just look into the ABCs of dementia, what is dementia? It is just a cognitive impairment, a progressive decline in intellect, memory, and language, behavior and personality changes with psychological symptoms, and activities of daily living impairment due to loss of functional abilities. Irrespective of what is the cause of dementia or nature of the dementia, there's a common core. Once we understand the common core, we also understand why we do particular tests to understand the extent of the disability. So the dementia is a progressive cognitive decline in all these spheres, like attention, the memory, language, visuospatial functions, executive functions, praxis, and behavior. So the individual is affected in all these domains. When the individual is affected in all these domains, there is going to be a functional impact. The individual is not going to be the same person as far as his day-to-day activities are concerned. This is what happens in any dementia, irrespective of the nature of the dementia. So when the attention, that is distractibility and inattention, are observed or at least elicited, what does that translate into the patient's behavior? It translates into difficulty in focusing on tasks at hand, frequent errors, incomplete execution, anxiety. In fact, this is the first sign of dementia, very early warning signs. Often the individuals who feel that all the while they were really doing well in their profession or in their day-to-day activities suddenly feel that they are not able to focus the same way as they used to do before. If he is still office going or working, he feels that he is making too many errors. Even if it is a housewife, she notices that her cooking is not as perfect as before. So there is an incomplete execution of various tasks. And this leads to a lot of anxiety. That is the reason why in the initial phases of the dementia, you may get a person, an elderly, with a lot of anxiety and to some amount of depression too. Memory, the episodic memory and semantic memory, both are affected, and that leads to difficulty in remembering events or appointments or problems in work and social spaces. So both the episodic memory and semantic memory are affected. And the language is another important aspect which gets affected in Alzheimer's and other dementias. So the person would tend to lose the fluency. You will have word finding difficulties, comprehension, and naming of objects. So this leads to difficulty in communication, understanding instructions, following conversations. A lot of times when we look at elderly patient, often we just focus on memory. It may not be that much affected in the early stages. Sometimes it may be the language function which is affected. So unless we try to carefully examine the different cognitive domains, sometimes we miss a case. Suppose if I am looking only at the memory, the patient sometimes may have very little memory problem, then I will reassure him saying that, okay, nothing to worry, you're feeling okay. But if I look carefully about its language abilities or its fluency, then probably I would know that probably there is an early sign of dementia. So one has to look into all the cognitive domains when looking at these patients. Executive functioning, the ability to plan and execute a series of tasks in order to produce a desired outcome. It is a complex mental ability which integrates various cognitive skills. I think in any activity, executive function, when it is impaired, the difficulty in self-care, activities of daily life, or gets affected like preparing a meal or dressing or even bathing, routine activities get affected. And behavior. When you look at the behavior of the individual, there is loss of empathy, impaired emotion, even the recognition of emotions in other spaces gets impaired. And there is a lot of difficulties in moral reasoning of the activities which they are doing, which leads to automatically impaired social functioning. Visuospatial difficulties start, and visuoconstructive, visuospatial, and visuoperceptual impairments occurs in dementias. So, which again shows in the form of difficulty in finding the routes, unable to find the way around their own house, unable to dress, unable to do activities like serving food or recognizing objects. All these things are manifested as behavioral changes. Praxis, impaired performance on learned motor skills. This occurs, they become very clumsy, slow, and stubborn while eating or dressing or driving. They continue to insist that they know everything, but ultimately you see that they are making a lot of errors. So this is a broad way of looking at the various difficulties the individual will have when he is affected with dementia. The types of dementia, when broadly we can say there are reversible dementias and irreversible dementias. As Dr. Anand was pointing out, often the neurologists are interested in reversible dementias. Once they know it is reversible, they spend very little time with the patients. So potentially reversible dementias, drug toxicity, metabolic problems, normal pressure hydrocephalus, tumor, chronic subdural hematomas, meningitis, collagen vascular disease like SLE, sarcoidosis, thyroid and parathyroid disorders, and more commonly vitamin B12, thiamine, and folate deficiencies. Lot of times, though we think that the person may be getting adequate vitamin B12 through his food and other things. For example, a common drug which is used by majority of the elderly, metformin. Metformin can decrease the absorption of vitamin B12 from the gut. And this, in essence, can produce vitamin B12 deficiency, and sometimes we find lead to cognitive disturbances. So we have to be careful in looking into various potentially reversible dementias. So irreversible dementias, of which we are going to focus more today, is Alzheimer's dementia, vascular dementia, frontotemporal dementia, and Lewy body dementia. I will not go into details of the other aspects because I personally feel that I should focus more today on how we really manage a case of dementia with a lot of Bpsd. So I think at some other time we can discuss about how to differentiate between all these dementias. But one thing which we have to remember is Lewy body dementia, where the usage of psychotropic drugs is going to further worsen the condition. A lot of times they tolerate the antipsychotics very poorly, persons with Lewy body dementia. So Alzheimer's dementia is our main focus today, and Alzheimer's disease is the most common neurodegenerative cause of dementia. 3 pathological hallmarks of Alzheimer's dementia: amyloid beta aggregated into plaques, neurofibrillary tangles composed of hyperphosphorylated tau protein within the neurons, and substantial neuronal loss. So these are the 3 things which are occurring in the brain, usually in the temporal and parietal areas, and also the hippocampus, which gets affected the first. Once the patient gets affected, he goes into through stages. Unfortunately or fortunately, the disease is such a prolonged thing. I have seen patients with diagnosed Alzheimer's go through all these phases and still surviving almost for 10 to 12 years, 13 years, 14 years. Tremendous amount of careless burden, but at the same time, a lot of the families, I do see them caring their loved ones to the end. So the mild degree that can stage of dementia can last anywhere between 2 to 4 years, with loss of memory, language difficulties, mood swings, personality changes, diminished judgment, and apathy. Slowly they enter to the moderate stage, inability to retain new information, behavioral personality changes, increasing long-term memory loss, wandering, agitation, confusion, and they require assistance. And severe when it becomes more of gait and motor disturbances, unable to walk, unable to perform ADL, needs continuous supervision, continuous care, and requires long-term care placement. If you look at these things, usually most of these people in India at least are taken care of by family members in different stages. It is not that as the patient is progressive, they are immediately shunted off to a care homes. So when we look at the diagnostic pathway, where does our concerns come? The persons with symptoms in the community. This person with symptoms in the community reach or have an entry point with any healthcare system takes a very long time. This is where the awareness is important. A lot of times people tend to say that it is age-related memory loss. Old man, anyway, he forgets. Why worry about it? Does it really is a disease? No, it is not a disease. It is part of aging. This is the commonest thing which we feel. But let us remember that age-related memory loss is different from Alzheimer's. Alzheimer's is a disorder or a disease, whereas age-related memory loss is just a process of aging. There is a lot of difference in both the things. This is where the awareness has to come. That is where probably observing like Alzheimer's, World Alzheimer's Day, or having conferences, having awareness sessions in various forums is important, so that people can be identified early. People can come to a healthcare facility early. Often, the first point of contact to majority of the elderly people is the family physician or the family doctor or to some other physician or a specialist physician for other disorders. I've seen a lot of times when the elderly person goes for a cardiac problem or any general health problem and tells the family member, he appears to be forgetting, Even we doctors comment, oh, old man, he forgets, don't worry about it, take seriously. His heart is okay, his BP is okay, take care of his BP, take care of his heart, take care of his gut, and there the subject ends. Very, very rarely we tend to see that probably this could be an early onset of dementia. So I think even our physicians, our colleagues, even the specialists, super specialists have to be sensitized about the possibility of Alzheimer's disorder. See, in our health system, the patient can walk to anyone. It is not necessary that he walks through a different referral route. So it is necessary for all types of specialists, all physicians to be aware of this. So once these local family doctor or a general physician identifies a probable memory impairment, could be because of a dementia, then the role of specialist comes, where it could be a neurologist or a psychiatrist. Very often, if the patient already has Bpsd, the patient automatically lands in the psychiatrist clinic, or if there are no Bpsd, often they go to a neurologist. So once the neurologist or the psychiatrist does do an examination and confirms the diagnosis of Alzheimer's, the communication is where a lot of us do not complete adequately. We do not sit with the patient and try to explain them what the diagnosis is about, what is the future consequences, what is the total route map or a roadmap of this disorder. The commonest error majority of us do, including me, probably is write a prescription and say, you come after 3 months, we'll see. So giving a sort of a message to the family that, okay, he is going to get better. His memory problem will be solved. So this sort of a messaging is often occurs in our clinics, and I think we should be wary of it now. So one of the important things is the post-diagnostic care pathway. What is this post-diagnostic care pathway? I'll come in the next few minutes. But this is the essential component of a care pathway in dementia. Diagnosis is okay. After diagnosis, what? In majority of the medical condition, often we say, once diagnosed, we can treat it and we'll see what best can be done to the patient. Here, once the diagnosis is made, how we are going to deal with the diagnosis and what is the post-diagnostic pathway which we undertake. So when I come to the diagnosis, the initial evaluation includes a thorough history addressing memory loss and cognitive dysfunction. There are some objective cognitive screenings and assessments, dementia-related laboratory studies, and neuroimaging. So history is an important component of the diagnostic process as far as dementia is concerned. As I said earlier, if we are concentrating only on memory lapses, your history is not complete at all. Somewhere you will miss. The patient or the family may say, no, he remembers. So one or two things he may forget. That is not a big issue. They will not be able to tell you unless you ask them for other specific details in the history. I'll come to that, what are those specific details. There are some functional assessment, staging, instrumental activities of daily living. One of the reasons why we have to have some objective questionnaires in evaluation of dementia is that it is not that we are going to diagnose and stop there. So I have to reassess this same person after 3 months, 6 months, or 8 months, or a year, or maybe more. So I should know what are his baseline faculties which were retained, which were lost, and which I can try to improve. If I don't have an objective assessment, then I'll be failing in my duty to arrive at a proper diagnosis and treatment. So some of the symptoms is, of course, from recognition of a familiar or unfamiliar people, difficulty in finding the way inside the home, unable to remember the way or route outside home, remembering names of people, unable to get the right word while speaking, unable to understand the words, unable to attend to routine household tasks, unable to count or handle money transactions, unable to understand or comprehend situations, difficulty in dressing or caring for personal grooming, difficulty in eating, incontinence, being more irritable, not interested in activities, not bothered about others' feelings, So these are all the symptoms which you have to keep on inquiring. Then only I will know how many of them are still persisting or the patient is able to do. And after 3 months, with my treatment or with my intervention, or am I able to retain them? Or is the person losing them rapidly? If I routinely make 1 or 2 remarks about the symptoms, then I will not be able to really assess my own intervention, whether they're effective or not effective. So these are all the symptom lists which we have to be aware of. Second thing is, if we are only doing a screening, a lot of times the relatives come. In a matter of fact, they say, I've brought my father. He happens to be forgetting. Would you like to see once? So when that question comes, when I have to screen an individual, there are very small instruments, very short instruments, which takes not more than 5 minutes or 3 minutes. For example, a mini cog, which takes just not even 5 minutes. So that it gives an indication that probably the patient might be having dementia, and then we can say, go for a detailed assessment. If he's scoring better, then we'll say, no, not necessary. We will see him after 3 months or 6 months if still you are concerned about the problem. The other common instrument which we use in the day-to-day clinic practice is AS3, Addenbrooke's cognitive examination, which is available in all the languages now. Telugu, Tamil, Malayalam, all the South Indian languages, including, of course, English Hindi versions are already there. So it's available in local languages, which can be administered to the patient. Neuropsychotic Inventory is another instrument which needs to be administered to the patient, because we need to know what are the various neuropsychiatric symptoms the patient is undergoing so that they can be handled. Geriatric depression scale is another instrument which routinely we use, and the carer burden scales to understand what the carer is undergoing. So coming to the investigations, it's mandated that every case where you think there is a cognitive impairment, at least the routine CBP, renal profile, LFT, thyroid profile, HIV screening, vitamin B12, as I said already, vitamin D and folic acid has to be routinely done for every case of cognitive dysfunction. Imaging, MRI will definitely show, if it doesn't tell you it is Alzheimer's, but at least it tells you that there is a significant atrophy in hippocampus, a significant cortical thinning, there is a significant dilatation of the ventricles. So it complements your diagnosis, and MRI definitely is useful more than CT. CT gives you some amount, but it's not more accurate. MRI we can go for, and PET, positive transmission tomography, which again tells you about the hypometabolism in areas where it is affected. Contrary to the earlier beliefs that there are no biological markers, now it has been established in the last decade or maybe 5 years, the different biological markers for dementia are there, and which will definitely tell you it could be in Alzheimer's disease. I will not go into many details of these biological biomarkers, but including the optical scans, CSF biomarkers are there, especially beta amyloid concentrations. Then in the serum, though the CSF studies may be a little bit cumbersome, even in the serum, there are various biomarkers which now are more or less standardized, and people believe that pre-Alzheimer's disorder can be relatively definitively diagnosed. And biomarkers are going to be really an important markers in the diagnosis of Alzheimer's in the currently even, and also in the years to come. These are some of the biomarkers which can be estimated but not routinely done right now, especially the probably only in some research centers they are doing. But for a clinical workup, I think MRI with a standard cognitive scales still clinches the diagnosis. So once we diagnose the Alzheimer's disorder or dementia, what are we going to do? Like I said, the post-diagnostic care, post-diagnostic follow-up is an important issue. the communicating the diagnosis to the family in proper way is an important thing. Never in the first interview say that your father or mother or grandfather is suffering from Alzheimer's. I have decided. So it is very difficult. So don't communicate that way. It should be a very leisurely session wherein you say your assessments are complete. You would like to discuss in detail about the management. Give a time for the relatives. Ask them to come on a particular day where you have some time. Spend time with them about communicating this particular disorder, how it is going to evolve. Never give a pessimistic or a nihilistic sort of a opinion about the management. To our own surprise, there are a lot of times when you think the patient is deteriorating, the patient starts improving or stabilizing. This I have seen several times in the last maybe 2-3 decades. They remain fairly stable in spite of suffering from Alzheimer's. So never give a very pessimistic outlook for the whole thing. Communicate to them saying that these are the limitations of the treatment. These are my limitations. But still, what is important is we can give a dignified life to that individual. We can make his life much more meaningful to himself and to his family. So this is the message which we have to give. Probably in the goals of management, one thing which we have to look at is how do I improve cognition so that dependence on the carers for ADL is minimized. So if I improve the cognition in some aspects, probably the individual may be able to do certain of his activities of daily life which are being carried out by one of the family members. Improve the behavioral and psychological symptoms of dementia so that he is not so restless, he is not so much disturbing the family. Then improve the quality of life of the patient. Ultimately, the quality of life of the patient, which is equally important. Postpone the need for hospitalization as long as possible. As long as possible, see that the patient need not get hospitalized or institutionalized. Minimizing the carer's distress and improving their coping skills. These are all my goals of management once I diagnose a person suffering from Alzheimer's. So let us look first into the pharmacological management. The pharmacological management of cognitive symptoms basically is cognitive enhancers are proven effective in mild to moderately severe dementias. When the MMSE roughly is between 10 to 20, and they slow down to some extent the deterioration of thinking and memory functions, the language and arithmetic orientation alertness, they do help significantly. And they help to maintain the autonomy for a longer period of time. So they have their own utility as far as the treatment is concerned. The symptomatic treatment of memory and cognition is by inhibiting acetylcholinesterase. I will not go into details, most of you might be already knowing. Donepezil and rivastigmine are the two drugs. They work by inhibiting the acetylcholinesterase so that the acetylcholine levels in the brain are more. And one NMDA antagonist, memantine. Usually memantine preferable to prescribe in the second and third stages. That is where it is much more useful in my experience. So coming to the management of cognitive deficits, the non-pharmacological way, that is equally important. During 70s and 90s, the emphasis on practicing skills and activation of cognitive functions were cognitive stimulation and reality orientation training. This was the emphasis during those decades. The principle was people with mild dementia have the ability to store information, and stimulating their cognitive reserve can benefit them. That means I goad them. Do this, though they say I can't do this, I keep on goading them. But it gave limited results. And sometimes it gave negative consequences from repeated confrontation with one's limitations. The patient is saying, I can't do it, and you say, no, you can do it. You are thinking that you are motivating, but on the contrary, sometimes it can be a catastrophic reaction to the patient. Because you will not understand why you are pressurizing him to do something which he is unable to attempt. So this concept has been given way. So focus shifted to emotion-oriented psychosocial approaches. such as psychomotor therapies, activity groups, engaging the patient in group activities so that even if he forgets, he looks at the other person and tries to imitate. And sometimes even validation therapies, validation that he has got a belief, something, you validate it through some means. And another thing is the reminiscence therapies, where you try to make the individual reminisce about some event, some episode, or even some object. So these are the things which help them to regain some of their cognitive faculties. These help to maintain communication and contact with persons with dementia and prevent them from becoming socially isolated and lonely. So this is an avenue of communication, which again is part of the cognitive training. Cognitive rehabilitation, cognitive training, is nothing but any intervention. It could be any intervention. It could be just even engaging them in a small walk, or a strategy or a technique which intends to enable the patient and their families to live with, manage, bypass, reduce, or come to terms with deficits precipitated by injury to the brain. So the brain is not effective in managing some of these things. So how I help, how we make the individual to some extent participate in the activity which he has forgotten. So this is all process of cognitive retraining. After identifying the goals, suppose the patient say, or the family says, this individual is not able to say button his shirt, or this individual is not able to hold his spoon and eat. So what is my immediate goal is whether I can make the individual do those two activities. So after identifying the goals, so it will be small goals. With these people, we have to set up small goals, and in dementia, the goal needs to be adjusted as time passes. The patient's disability may be increasing sometimes, or the patients might be recovering from certain deficits. So you have to change the goal. So it depends upon the therapist there who is attending to them. And this is an important way of, non-pharmacological way of doing things. CST, cognitive stimulation therapies in group settings, activities are carried out based on particular themes. Example, childhood, current affairs, nutrition, numbers, word games, quiz, creativity, categorizing, using money, etc. So you follow an established pattern in a group setting, and these are the programs which we routinely do. CST program was studied in an RCT for its effect on cognition and found to have positive effects on cognition, which are comparable to cholinesterase inhibitors. This improved quality of life also. So this is where the CST in group settings are important, and one has to look at them. So memory groups, movement and psychomotor therapies, reminiscence, activity groups, validation therapies, normalization of living environment, light therapy. Light therapy is one aspect, but at this point, let me remind that the elderly people, this often we forget. Elderly people require very bright light. Even if you don't have dementia, even the elderly person doesn't have dementia, the requirement of light for an elderly person is almost 60% more than a person who is younger to him. That means if a 30-year-old person is staying in a living room and with a bulb which is 60 watts, the same amount of light is not sufficient for a person who is above 65 years. He requires at least 90 watts. Often we tend to keep our old people in rooms which are poor lighting. That increases their confusion. So it's a matter which has to be remembered by all of us, that the living rooms or where they are moving has to be brightly lit, including non-dementias. Dementia is much more necessary, but the light is very important aspect of people trying to orient themselves. So that is as far as the cognitive aspects are concerned. The behavioral and psychological symptoms is the biggest bugbear for all the psychiatrists, and all of us know how difficult, how irritated we become. You prescribe a drug, the patient comes back, the relatives come back, nothing is happening, he's not sleeping at all. Next day you change the drug, they will say he's become agitated. The third day you prescribe another drug, they say he's not sitting at one place, he's running around. So you are faced with so many problems when it comes to BPSD, and we have to know how to really manage it. So behavioral symptoms, BPSDs are behavioral and psychological symptoms of dementia. So the behavioral symptoms are identified on the basis of observation of the patient: physical aggression, screaming, restlessness, agitation, wandering, culturally inappropriate behavior, sexual disinhibition, hoarding, cursing. Each of these behaviors can be managed to some extent non-pharmacologically. I think time doesn't permit, otherwise I could have taken each behavior and explain how to really deal with that. Assessed on the basis of psychological symptoms or assessed basically on the basis of your interview with the patient, the mental status examination, or from the relatives, interviewing the relatives. So anxiety, depressed mood, hallucinations, delusions, and psychosis. So BPSD basically results in a lot of suffering, not only to the individual, but also to the family and the carers. It can lead to institutionalization if not properly managed. It can also make increased costs of care. It leads to increased costs of care. It leads to significant loss of quality of life. So that is the reason why we have to, and also remember that 90%, or it can be even 100% of the persons with dementia or Alzheimer's will have BPSD at some part of their illness. Some part of their illness. It is not that some people are going to escape this. So almost every patient with Alzheimer's disorder will have BPSD at some point of time in their illness, as long as they are alive. So non-pharmacological interventions are usually the first line with BPSD for milder BPSD problems. Without an environmental trigger, problems without an environmental trigger that are severely distressing to the caregiver require medication. See, most of these BPSDs to a large extent can be environmentally triggered. So that is the reason why we had to look into initially non-pharmacological interventions. Symptoms that are most responsive to non-pharmacological interventions are mild depressions, apathy, wandering behavior, pacing, repetitive questioning, and mannerisms. There are ways to manage these problems. So coming to the pharmacological management of BPSD, before starting medication, don't be in a hurry to start the medication. Put these questions to yourself before you start a particular drug, before you prescribe. First is, does this particular symptom which you have found or the behavior which you have seen warrant drug treatment at all, and why? Why am I using this drug for this behavior? Is this symptom drug responsive, first of all? If I give the drug, is this symptom going to disappear? Which category of medication is most suitable for this symptom or behavior? What are the potential side effects of this drug? And how long should the treatment be continued? Unless I answer to myself all these questions, there's no point in me putting my pen on the prescription paper. I have to find answers for all these things so that next day when the patient says this is happening, I should be able to really convince him. The second main thing is, a lot of times, do not expect the result overnight. This we have to educate the family. I have prescribed the drug, it will take some time, including when sleep, sometimes it may not improve. That mistake sometimes which we may do is, in our own hurry, we try to add multiple drugs, which is again going to be counterproductive. Another important factor is, when suppose I start some drug with 2 milligrams, next day the patient says something, I'll make it 4 milligrams, that day 6 milligrams. No, that sort of a strategy will not work out, because a lot of times the elimination in the elderly people is very slow. So you will end up with a cumulative drug response at the end of 3 days or 4 days, and wherein the patient is totally down, not even opening the eyes. More than the behavior, now the family will be worried about how to wake up this person. Previously, they were asking you how to make this person sleep. Suddenly, they will come out and say, how to wake up this person, tell us. Because in our anxiety to help the persons, we gave the medicines too frequently so that there is a cumulative effect and the patient is not able to tolerate it. So treatment of BPSD should be evaluated. Any patient with BPSD, initially before you start the treatment, should be evaluated for delirium. Because delirium superimposed on a dementia can present with a lot of behavioral symptoms. Next thing is consider changes in environment, medication. Sometimes it could be just proper physical examination is necessary at this stage because sometimes it could be fecal infection or it could be pneumonia, it could be urinary infection. These things can trigger the Bpsd. Another thing is because they are not able to communicate to you, sometimes even pain itself can induce a behavioral problem. There are occasions when we give a painkiller, the patient sleeps off because there may be some tooth or some gum infection, some tooth pain, or some sore at the back which you didn't check. So these things, you just give a paracetamol, the patient might sleep better than your sleeping pill. So sometimes it is necessary we evaluate all these things. Behavioral management or situational manipulation are the initial strategies of choice for mild to moderate Bpsd. The situational manipulation sometimes is easier said than done. It depends upon the carer's interest, how much they are tolerant to to bring in these changes in the environment. All these things also matter. So pharmacological interventions are useful if symptoms are severe or do not respond to non-pharmacological strategies alone. Medications for Bpsd, different symptoms in dementia arise from different anatomicals. One thing we should remember is all these behavioral symptoms, all these Bpsd are not random events. They're not random occurrences in an individual suffering from dementia. They are because of circulatory disturbances at specific areas which are affected in dementia. So we have to take cognizance of it and try to see, whatever could be the cause of neurodegeneration, ultimately the final common behavior pathway is the same. So the symptoms are attributable to neurocirculatory malfunctioning, and we have to address these symptoms. So medications, if it is a psychotic symptom, go for an antipsychotic, but start with 0.25 milligrams of Risperidone. It's always necessary to remember that the lowest possible dose which you can give it, and then carefully titrate it for a period of time. Antidepressants are useful. One useful thing about Trazodone is its half-life is very low, it's 8 hours. So usually when you use Trazodone for sleep, it is quite useful because it works only for 8 hours. There is no hangover effect or drowsiness effect of Trazodone when you are using it as a sedative. Of course, sertraline, all these things go to the lowest possible dosages. Mood swings, of course, only 2 generally employed, valproic acid and carbamazepine. If it is a lot of restlessness, irritability, anger, personally, I prefer carbamazepine to valproate. Agitation, apathy, irritability sometimes can be helped by cholinesterase inhibitors. So donepezil or rivastigmine. Sometimes rivastigmine is much more useful when there is an apathy and irritability in some cases. Anxiety, short-term use of short-acting benzodiazepines are useful apart from non-pharmacological techniques. But as I said, in geriatric thing, start low, go slow is always a dictum. You have to convince the relatives saying that it is going to take time for the response to occur. Don't be in a hurry, otherwise we'll end up with more side effects than the original problem itself. Another recent thing is for psychotic symptoms. This is actually approved for Parkinsonism, psychosis in Parkinsonism, pimavanserin, the selective 5-HT blocker. This is one drug which has been recently introduced, but I don't think it's available in India. This is basically useful in psychosis in Parkinsonism where you don't want to give D2 blockers. So this is one drug. For agitation, brexpiprazole, again, right now we have only aripiprazole, this is not there with us. Dextromethorphan with bupropion is again useful for agitation. Unfortunately, dextromethorphan alone is not available for us, but it's a mixture in almost all the cough syrups. It is an antitussive cough suppressant. So this, in addition, when added to bupropion, is supposed to control the agitation. So sometimes the old dictum like you give a cough syrup, the patient happily sleeps off. Probably there is a logic there. This appears to be controlling the agitation. Dextromethorphan with quinidine is useful in pseudobulbar effect. Especially this again occurs in other neurodegenerative conditions like amyotrophic lateral sclerosis and other neurodegenerative things where there is a lot of emotional ability, sudden bursts of laughing, sudden bursts of crying, that what we call the pseudobulbar effect. This combination is supposed to be helpful. As I already told, Trazodone for depression and cholinesterase inhibitors for apathy. These are some of the drug treatments for. So, as far as the drug treatment is concerned. So, what are the key factors in organizing dementia care? See, basically, dementia care is a multidisciplinary care team. So, you need a dedicated doctors, healthcare professionals, psychologists, speech therapists, social workers, and sometimes volunteers, sometimes the family members work as volunteers. So prioritizing your objectives based on the resources, funds, and time, engaging with the patients and the caregivers, building credibility, prototyping the services at a small scale. Whenever you are planning to do something with reference to dementia care, you have to have a plan. Is this going to work? So to that, you have to have some sort of a small pilot project. Put that pilot project into practice, see how it gets you the result. The results are meaningful, then go or escalate it to a larger population. This should be the strategy as far as dementia care is concerned. So we have to liaise with hospitals and NGOs, partnerships for speedy delivery of services. Lot of times, dementia care is not a single man's effort. Dementia care needs a combined effort from different healthcare professionals. So some of my experiences have been associated with ARDSI almost. The ARDS Hyderabad currently is for the last 15 years it has been in operation. Earlier to that there was another organization of which I was also a part. So some of my experiences, in fact at that time Dr. Suvarna was there in Hyderabad, right now she's in immense, but we could stitch up some sort of a team which included some psychiatrists, psychologists, speech therapists and caregivers, and started a sort of a journey through which we could help at least, maybe I won't say a very large number, but a very small number, at least those small number were really happy about the services which you could offer. This is our current daycare and activity center where people come either once a week, some people come twice a week, some people come thrice a week, some people come daily, but it is open. Anyone can come and take the advantage of all these cognitive stimulation exercises. All the four of them, 1, 2, 3, 4, are suffering with moderate level of dementia, and they engage themselves. Sometimes they talk among themselves. This is again one type of activity. It's cooking. So this lady says that I forgot some steps. We say, okay, bring. Our volunteers will teach you what are the steps, whatever the dish you want to make. So this sort of a encouragement and engagement. This is again the same group trying to be together. And imagine these were the people whom the family says they don't sit at one place at home. They keep moving around. They disturb everyone. We are not able to manage them at home. But once they come to daycare center, once there is an interaction, once there is some amount of communication happening, their restlessness and these things comes down. So by these procedures, by doing this sort of a daycare activities, what is the outcome which you have seen in the last few years? The outcomes are, it is slowing of cognitive decline, definitely. Impairment of activities of daily life was better addressed by the caregivers so that they could. Behavioral disturbances like apathy, depression, and restlessness improved when the patients attended daycare activities. The same 3 symptoms were the biggest challenge for the family to manage at home. Caregiver distress could be minimized. At least few hours of respite they had. Support groups helped in solving certain problems faced by the patients and caregivers. So they come up with some problems, then a lot of times what happens is when the relatives sit together, we have a caregivers meeting on every second Saturday of every month, so that whether they are coming to daycare center or not is immaterial, so they come. Recently, we started online sort of a cognitive remediation therapies, which sitting at home, probably they can participate. So in conclusion, dementia care is not a clinic-based or hospital-based care. It is a multidisciplinary approach is needed. I cannot say I'm practicing or helping a patient with dementia sitting in my clinic. Sometimes I may have to make a home visit too. So it's not a hospital-based alone. Admitting the patient of dementia in a hospital is not going to do anything. Multidisciplinary approach is needed. Medication is only part of the treatment, and psychosocial treatment takes the precedence. And dementia care program can be organized with the help of locally available resources and active involvement of the affected families and a committed initiative of the medical team. One need not have a elaborate finances, elaborate thing. It can be like if you're a clinician, half a day in a month, you can devote, say, I see only dementia patients along with the relatives, conduct a group meeting. So this sort of innovative thinking or innovative steps we can take to, because why I'm saying these initiatives are necessary, that in the years to come, especially the younger psychiatrists will be seeing more and more of these disorders. They'll be seeing more and more of these people, and they have to tell answers to the relatives. They have to tell them how to mitigate their sufferings. And this is the only way, involving the families, trying to take more initiative of helping them. And with this, probably we can at least help few patients with dementia. Once again, I thank you for giving me this opportunity to talk few things about what I have learned in the caring of dementia in the last few decades. Thank you.
Thank you, Dr. Chandra Sekhar. As expected, that it is the most practical approach that can only come from a person who is actually dealing with such problems. Knowing it only from the books or seeing will give us very few inputs into what to do with these people. You may have some ideas, but actually when we execute these ideas, we know actually what problems are there and how to deal with it, which has been aptly dealt by Dr. Chandra Sekhar, who is the speaker today. As it is said that what cannot be cured has to be endured. Endured does not mean endure with suffering. So the goal of the dementia care is to minimize their problems and suffering. It is not only that, he has made a very good statement, make life meaningful. The central theme in the presentation. He has covered the various aspects right from the diagnosis and focus mostly on the behavioral and psychological symptoms of dementia, how to understand them, how to assess them, and then what are the different strategies which can be adopted. Apart from that, the pharmacological management is what's called the practical psychopharmacology, that is what is important. In many cases, you'll find that the geriatric problems plus dementia problems are there. So we need to tackle both of them. I think the confusion would be that people would think that dementia problems are similar to geriatric problems, but one should try to differentiate some of them and try to manage them. So this is the message which we get from today's talk. So for any questions, any questions are there in the...
Sir, there is one comment, sir.
Yes, Dr. Pawan, to, in case he has any in the charts or question and answers, kindly, Pawan. Are there any? Or they can probably raise, they can make themselves visible or raise their hand on the icon which is there and then ask a question. What do you feel, Dr. Pawan?
Sir, there is one comment, sir, from Dr. Bala Tripurasundari. Excellent and very informative session, sir. Post-diagnostic care path is very critical as the progression milestones are very relative and differ from person to person and needs to be very, very objective. This is one comment received in the chat box, sir. Then I'll just check the. Dr. Sami Hussain Usman was to talk, sir. Dr. Sami Usman.
You can unmute yourselves, Dr. Sami. You're still.
We have to take him on the panel to.
So there is one question from Dr. Madiha.
Madiha.
Yeah. I have two questions, sir. Thanks a lot for explaining more practical way of approaching patients with dementia. Two questions, sir. How to counsel caregivers regarding palliative care in case of terminally ill patients with dementia?
How to? Terminal illness.
You're asking about palliative care in
more of a palliative. See, as far as the dementia is concerned, or any of these, the relatives as such would have already been exposed to the various deteriorating stages of the life of this individual. So they would have been going through the grief process already, and only what you have to probably is lending them a sort of a opportunity to ventilate their emotions about the individual who is going to probably being not going to be there in the next few days. So this sort of a ventilation about talking about his positive aspects of that person when he was active and these things, and that reminiscing of various positive things would help these patients not suffer. See, a lot of times the carers undergo a lot of guilt. One of the commonest emotions is guilt. I didn't look after him when he was a little bit more active. I didn't look after him when he was capable of. I didn't give him what he wanted when he was in a position to eat. So these sort of things are the guilt-ridden messages. If you help them to handle, that is one way of counseling which can happen during this period.
Sir, what are your experiences in treating young patients, particularly around 35-40 years with dementia, and reactions of the caregivers? Please share your experiences.
I haven't seen many of that category. Basically, very young people coming with neurodegenerative conditions. Personally, I haven't really come across. Probably the same principles would hold good. See, one of the things which we have to really focus on that sort of individual is for the carers is more of a guilt. How they handle their guilt is the important aspect. The second thing is how they can improve the quality of life of that person in the existing circumstances. So I would focus on these two issues. We'll discuss with them what are the minimal things they can do to improve the quality of life for this individual who is suffering. Second thing is how they can get over that guilt. What are the situations which made them undergo that emotion? I think if we are able to tackle these two things, most of the time they feel comfortable.
Sir, in these young patients, can we suspect any organic problems? Particularly, day before yesterday, I got a patient around 36 years with severe dementia, loss of cognitions, loss of memory, and all those things are there.
They have to be investigated for other causes of neurodegenerative conditions.
She's only 36.
No, that's what I'm saying. Even HIV sometimes can cause these severe dementias at a very young age.
So there's another question, sir, from Dr. Madiha. Can you share your experiences about RTMS in patients with dementia, sir?
RTMS, I haven't tried, but they claim, but I don't think it will be maximum. If there is any depressive component, probably it may help that part of the symptom. But for cognition, I don't think RTMS will really be helpful. Probably if there's a overlaying depression, especially in early stages, probably, yes. But I don't think it is a choice, though they claim. There are some studies which claim that RTMS can be tried, but I don't think it has got any relevance in day-to-day clinical practice.
Sir, thank you, sir. There's one question from Dr. Sami, sir. I'm GP. Is Alzheimer and dementia same?
Alzheimer's is one type of dementia. Dementia is a broad term, global term. Any cognitive decline because of any condition is termed dementia. Alzheimer's is one type of dementia, which is a irreversible type of dementia.
Yeah, there are a couple of other questions are there.
Rivastigmine with respect to dose strengths and any specific indications where it can be started, sir?
Rivastigmine is usually started in the early and middle stages of dementia. The dose is usually available as both patches and oral preparations. Oral preparation, the average dose is about 6 to 12 milligrams. 12 milligrams is the maximum. Usually you start with 3 milligrams and go hike up. If it is a patches, it is given 4.5 milligrams per 5 centimeters patch, or usually you go up to 9.6 milligrams patches. So it depends upon the patient's affordability, and it's one of the costly drugs compared to donepezil.
And any specific indications where it can be started, sir?
There's nothing. See, this is for improving the cognition. It is useful, but there's nothing like that. Any dementia can be started on a cognitive enhancer to see that the cognitive functions don't deteriorate fast.
Sir, thank you, sir.
So obviously, we tend to use it only in the early and middle stages. When the patient is almost bedridden, it doesn't know much value there. The terminal stages is not much of a value.
Thank you, sir.
There is another question on what is the choice of drug? I think PD means Parkinson's dementia with psychosis, other than pimavanserin, patients with monodelusions, to be specific, sir.
We have to go only for clozapine. Clozapine is one drug which can be useful, or the least.
Can quetiapine can be used, sir?
Quetiapine can be used, but quetiapine, the problem is if you want to have an antipsychotic effect, you have to go for a very high dose, which is not very appropriate to use in elderly people because of QTC problems and other things. It is not an appropriate drug in large doses. The other nearest is we can try aripiprazole.
I have a question. This is regarding, there are so many youth who are educated but unemployed, who are also frustrated. Are there any training programs? Any training programs in dementia care?
Yeah.
Do that. And does it lead to any certification or something like that?
Yes, there are different training programs, certificate programs in dementia care.
Yeah, this can lead to self-employment.
Yeah.
But the only thing is that many people are not aware of such things.
Yeah.
Another question is from Dr. Rishikesh, sir. How far neuroimaging is important in different types of dementia?
Neuroimaging is definitely one of the investigations required. We do it. Neuroimaging is, now it has become almost necessary that if you are making a final diagnosis of dementia, neuroimaging is almost necessary. You should complement your diagnosis.
And there's one question by one anonymous attendee, sir. Rehabilitation treatment, young dementic signs, post-rehab after substance-induced dementic signs. I did not get the answer. Question correctly, sir. Rehabilitation treatment, young dementic signs. Okay, we will leave that, sir. It is not properly framed. Another question is from Dr. Harini. Does hypnotherapy work in dementia?
Hypnotherapy?
Hypnotherapy.
No.
I've seen somewhere that one type of, some cap is used with some lights and all that. I think I was really fascinated to see that. With I don't know what is that type of therapy called as, but this is there in diagrams also.
Yeah.
Give different types of lights.
Lights. See, this one technique where the patient is severely agitated. There is some people in some residential dementia residential care centers, they use it. You keep a room, there's a lot of lights where the attention immediately shifts. When they are very agitated, you take them into the room and leave them. A lot of either you put it as a cap or you show them the lights around. They are supposed to slowly calm down. This is one thing. And of course, there are other things which I forgot. Even our so many other things. Even your curcumin, the turmeric which we use daily is supposed to be a preventive thing, decrease in the amyloid plaques. Then we have ginkgo biloba. Then you have so many other things which are useful or claimed to be useful, various plant products. Ultimately, one thing is that if you, preventive thing is only taking care of your BP, sugar, and other things, taking adequate care, no head injuries, don't in the elderly group, try to avoid head injuries. Then other important thing is about physical activity, physical exercise, and some amount of cognitive stimulation. Physical activity is supposed to be useful still, and cognitive stimulation, puzzles, interactions, social interactions. These things will delay the onset of dementia.
Sir, there is one question, sir, from Dr. Bharti Chella. Which is the best diagnostic tool for early dementia?
Now, the even thing, these biological markers which we have listed, they are supposed to be even preclinical stage, they are supposed to detect. But people are a little bit scared to undergo them because at least the next 30, 40 years of your life, you are worrying about the onset of dementia. Now, most of these biomarkers are more or less standardized.
Sir, Dr. Harni says hypnotherapy, they are charging 80,000 rupees. There's one more question from Dr. Soni Ghosh. How to counsel caregiver about how to deal with the behavioral disturbances of dementia patients?
It depends upon the nature of the behavioral disturbance. Somehow, see, very often, this is what I'm saying. There is a list of it, which each one can tease how to really challenge that behavior or control that behavior. It is not a all-in-one phenomena. One has to look at the behavior, analyze the behavior, why it is occurring, and then give a sufficient. Like I said, sometimes simple thing like improving the light of the room will stop them from getting agitated. It depends upon what is happening.
So, with the permission from the chair, sir, Chandrasekhar sir, I have noticed one thing, sir. Initially, when we see the patient first, sir, I think it would be ideal to see them frequently, because talking to them and watching up close and looking at their behavioral issues, I think then you start on some medication, you go low and slow. I think 3-4 visits, I think that will also give us a lot of sir, option to counsel the caregivers, I feel, sir.
A lot of things I learned in the last 5 years after this respite care long-term dementia care center, which we have now with about 30 patients with dementia. How much minimal medicine we can use, how to control their behavior without immediately jumping on to give some. So there are no SOS medications there in that center. Like, though there is nursing staff, we generally tell them not to give any SOS medication, observe the behavior. Next day, we will see what has to be done. Most of the time, it will be a transient behavior. Another important thing which I forgot to mention is that once you start an antipsychotic or antidepressant, it is not like what we treat the adult regular patients of a certain period. Here, as soon as the behavior is controlled, you tend to taper off the drug. You don't give the antipsychotics for months together. It is not necessary because the behavioral symptoms keep changing over a period of time in dementias. It is not like schizophrenia where I start the drug, continue it for 1 year because there is a psychotic symptom which responded. Here, if the patient has responded, wait for 3 to 4 weeks, remove the drug, watch, if necessary, start again. No need to continuously give that particular drug because the behavior for which you have given that might have stopped long time back. So there is no need for that sort of a strategy here.
Sir, one question from me, sir. Like in my UG days or PG days, we used to be taught like smoking and Parkinson's and dementia have inversely relation. So those who have smokers will not get Parkinson's or dementia. But then when I asked this to one of the professors, they said smokers won't live up to that age where they can have these things.
That is a common answer. There is
no,
there is no scientific basis to explain that.
Yes.
Sir, this reorientation, time, place, date, and everything, keep on remembering or keeping a big date, everything. Will it help, sir?
It will definitely help. Definitely help. See, in fact, I recommend a lot of times. There are calendars where you have to tear off the thing. Old time they used to get this bunch of dates. Each day we tell the person to tear off one, so he knows the next day.
Yes.
So these sort of a thing, or putting a clock in their room. As far as possible, try to remember the time. Putting a clock with which gives the bell every hour. 2, 3, things like that. These are all the families which need to show some interest and do it.
Giving breakfast, lunch, dinner at a particular time every day.
And telling them that what they're having at that particular point. So there's one question from Dr. Bharti Chella again, sir. Is there any noticeable improvement with donepezil and memantine, or have they really stalled worsening? And which is the best low-dose antipsychotic for behavioral symptoms, and which is the best drug for the sleep disturbances alone? Because lorazepam is usually seen as seen to exacerbate.
For sleep alone will be usually melatonin. It works, most of them, provided you give it quite early in that day. Sometimes in the 5 o'clock or 6 o'clock you have to give. At least 3 to 6 milligrams of melatonin is always useful, but always administer it around 5 or 6 o'clock or maximum 7 o'clock, not beyond that. That's one way of managing. The second thing is about lowest dose of I think most often Risperidone 0.5 milligrams will be the ideal starting low dose, or even about 0.5 milligrams of aripiprazole, depending on how you get it. What's the other thing?
Sir, is there any noticeable improvement with the donepezil and memantine?
See, this is what I'm saying. There will be noticeable improvement provided you had your baseline assessment properly. Unless I have a baseline assessment of on some scale, definitely there will be a noticeable improvement. Memantine usually better to start in the later stages. The first I would always prefer donepezil, and maybe after say 6 months or a year or so, memantine. Because memantine is basically an MDA, the glutamate sort of a thing it controls. Usually it is seen in the later stage of dementia. Earlier it is acetylcholine.
So Dr. Daljit asks, at what stage do we ask the family members to discuss about the financial arrangements, whether they have made a will or not, or it is often sensitive issue, and the patient, if mild to moderate on presentation, can feel offended?
No, that's what I was saying. So once you are doing that discussion about the diagnosis, after the final diagnosis is made, you have to take time and discuss all these issues. Tell the family that this is going to be the roadmap of this illness. Right now, if the individual is able to understand and coherently respond to them, this is when they have to take the decisions. I mean, this is the counseling which is required once the diagnosis is made. So that when you do it in a hurry in a clinic, it is very difficult. So it is like a psychotherapy session. You have to call them for a 1 hour session, sit with them, explain to them, and then give them all the possibilities. The decision is theirs. That's a different thing. But you have to tell them these are the things which are going to happen in the next few months to years. So try to take the precautions what best you can do.
Sir, with the permission from the chair, sir, I would like to thank Dr. G.V. Raman Rao, sir, Dr. Ramesh Babu, sir, Dr. Bendi Sairam, Dr. IVL Narasimha Rao, and Dr. GSP Raju, sir, and Dr. Lakshmikant Rati, sir, for joining this webinar, sir. Yeah, Pawan, please go ahead.
Sir, one anonymous attendee asked, sir, post-COVID related psychiatric phenomena have you noticed, sir, with regard to dementia?
There's not much of exacerbation. Like I see, out of, my own personal experience is about almost 20 to 28 of them had COVID in my setup. All of them recovered from COVID. Their condition did not significantly worsen after COVID. They more or less maintained the same sort of a cognitive status as before COVID. But there are reports that people who are affected with COVID had neurocognitive disturbances for the first time in their life. Those reports are there.
And sir, paracetam and can melatonin be given after 7 p.m.?
Can be given. The problem is melatonin takes a longer time. So whether it acts or not is a moot point. It's not that you should not give, but to be effective, if you give it between 6 and 7, I have found a lot of times they do have a sufficient sleep.
Sir, melatonin, I have seen that many a times, melatonin helps in psychotic features too. Like when we, along with donepezil, if we start melatonin, patients having early dementia, and if we start melatonin, not any antipsychotic, it does help. What is your experience?
No, in the sense that, see, most of these people, if the sleep is properly restored, some of these symptoms also do respond.
And what are the doses of melatonin we can give, sir? I have given up to
10 milligrams.
15 milligrams?
Up to 10 generally.
10. Okay. Sir, what is your opinion about nowadays many people have started living in flats and very small flat nuclear families, and there are elderly who are disturbing. So what are the chances that we'll require more rehabilitation centers and bigger centers for dementia apart from old age homes?
See, demand is, the need is always there. Need for that sort of a centers is always there.
Do we have any centers in India, such center in India? Like I know that you run a center for dementia, but do we have many such centers?
There are centers in a lot of cities have got.
Sir, do they take mild, moderate, or severe dementia patients?
No, usually it is when the patient's relatives require that they are not able to manage the patient, then they approach these centers. If the patient can be managed at home, I always suggest them, only if you are not able to manage at home, please bring. See, the first thing which I tell them is, what is the difficulty in managing this patient at home? If they are able to manage, there is no need for institutionalization. Of course, there are some social reasons. Sometimes there is no person living here, they are abroad, there is no one to take care of these elderly people. And those are all social reasons. But clinical reasons, I would say, unless they are very specific, there is no point in keeping them in the institute.
Thank you, sir.
Are there any more questions?
No, sir. No, sir.
Okay. So we had a fruitful and very practical discussion, at least for about half an hour after the talk, and it was quite informative. I thank Dr. Chandra Sekhar and all the participants. Now I hand over to Dr. Pawan and
Thank you, George, for this memento. Thank you very much.
Sir,
Thank
you.
you.
Thank you very much, sir, for excellent lecture and very good discussions. Thank you very much. How explained us in a very nice way, particularly practical way, how to deal with the dementia, and particularly how much doses we have to give. All these things are very well covered, particularly a general practitioners like me. Thank you very much, sir.
It was great listening to all of you, sir. Thank you, sir. Sir, over to George, sir.
Yeah.
Now request Narendra sir for the vote of thanks, sir.
I would like to express my gratitude to Dr. Chandra Sekhar sir, who had readily agreed and delivered an excellent lecture for all the participants. And I like to thank Dr. Anandraju sir, Dr. Anand Bogaraju sir, and Satish Babu sir for accepting to chair the session. I like to thank Sigmund Pro Medica for sponsoring this program, and our president, Dr. George Reddy sir, and Pawan Kulkarni sir for giving me the chance to deliver this vote of thanks. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Sir, thank you, sir.
Thank you.
Thank you, George and Pawan, for giving me this opportunity.
Sir,
Thank you, sir.